Hello everyone, welcome to another episode of Dental Digest with the Study Booths. I'm Dr. Trehan, and today we are continuing our series on odontogenic tumors in oral pathology. And in this episode, we are going to specifically focus on Adenomatoid Odontogenic Tumor, that is AOT. Now the roadmap for this session is going to be that we are going to go over the basics of AOT, starting with its origin and etiology, then pathogenesis, then we'll move on to clinical and radiographical features. After that, we'll review the histopathology, some possible complications, treatment options, and then differential diagnosis. Let's begin with origin and etiology of Adenomatoid Odontogenic Tumor, or AOT. Now, AOT arises from odontogenic epithelium, most likely from the dental lamina remnants or reduced enamel epithelium that are left behind after tooth development. And on the generic side, AOT has been linked to mutations in the KRAS gene. Let's talk about the pathogenesis of AOT now. Now, the process begins with proliferation of odontogenic epithelial cells, which then arrange themselves into a characteristic pattern, including duct-like or gland-like structures that give AOT its adenomatoid appearance. Now, a unique feature of AOT is presence of amyloid-like material within the lesion, and over time, calcifications may develop within the material, contributing to its distinctive radiographic and histological appearance. Another important point is that AOT is usually surrounded by a thick, fibrous capsule. And this capsule acts like a natural boundary that helps prevent the tumor from infiltrating into the adjacent bone and soft tissue. And that is why AOT behaves much less aggressively than any other odontogenic tumors. Now let's discuss the clinical features. Now this tumor is typically slow growing and asymptomatic, so most of the patients don't really report them. Instead, they may only notice a gradual painless swelling in the area. And AOT shows a clear age and gender predilection. It is more commonly seen in females with about 2:1 female to male ratio, and it's more often occurring in young patients between 10 to 19 years of age. And then location-wise, AOT also has a strong predilection for the anterior maxilla, and it's frequently associated with impacted tooth, most commonly impacted canine. Now, this combination of young patient, anterior maxillary location, and impacted canine is very characteristic and helps distinguish AOT from other lesions during clinical examination. Now, radiographically, AOT appears as a well-defined unilocular radiolucency as a single clear radiolucent area, most often surrounding the crown of an impacted tooth, typically which is going to be maxillary canine. Now, a key point to note here is that AOT can actually show you mixed radiolucent or radiopaque areas because of small calcifications that form within the lesion. And these small radiopaque flecks inside the radiolucent cavity are classic feature of AOTs. Now, another important radiographical clue here is that radiolucency frequently extends beyond the cemento-enamel junction, so the lesion surrounds not only the crown but also partially envelops the root. And this extension beyond the CEJ helps differentiate AOT from simple dentigerous cyst, which usually only surrounds the crown component. Let's talk about the histopathology now. Now, microscopically, the epithelial component of AOT can show several growth patterns. It may appear nodular, trabecular, cribriform, or it can also form duct-like or rosette-like spaces that gives it glandular appearance. Now, these tumor cells may actually be spindled, cuboidal in nature, or columnar. And a very characteristic feature is that the nuclei tend to palisade away from the lumen of the duct-like spaces, lining very neatly along the outer edge. And that is the key diagnostic clue here. Now, the lesion is typically enclosed within a duct fibrous capsule, as we talked about earlier, which is going to limit its spread and correlates with its non-invasive behavior. Now, the lesion is typically enclosed within a thick fibrous capsule, which limits its spread and correlates with its non-invasive behavior. In addition, amyloid-like deposits are frequently present within the tumor, and calcifications and eosinophilic material are commonly seen, which contributes to its mixed, distinctive microscopic appearance. Now let's talk about complications. And the thing is, complications are really limited in AOT because it is very well encapsulated. Now, it can cause some displacement of associated tooth, especially in the impacted canine area. However, unlike more aggressive odontogenic tumors, AOT typically does not cause any root resorption, which is very important distinguishing feature here. Now, the recurrence rate of AOT is extremely low when you compare it with that of ameloblastomas. It is reported to be less than 5%, making it one of the least recurrent odontogenic tumors and supporting its excellent overall prognosis. Now let's move on to the treatment of AOT. Now, the primary treatment of choice is surgical enucleation, which means carefully removing the entire tumor along with its fibrous capsule. Now, curettage of the surrounding bone must be performed to ensure all the tumor tissue is removed properly. And in many cases, especially in young patients, surgical and orthodontic approaches can also be combined to preserve the impacted tooth associated with the tumor. Now, in few cases, we can combine the surgical and orthodontic approach where we can preserve the impacted tooth associated with the tumor whenever it's feasible. Now, after enucleation, follow-up is recommended, but given the very low recurrence rate, long-term outcomes are usually excellent with complete resolution in most of the patients. Now, let's talk about differential diagnosis. Now, several lesions can mimic AOT clinically and radiographically, so it is important for you guys to understand and distinguish between them. Let's talk about dentigerous cyst first. Now, this cyst is also associated with an impacted tooth, and it can look very similar on radiographs. However, dentigerous cysts usually attach at the cemento-enamel junction and lack the gland-like epithelial structures, a myeloid-like material, and calcifications that are characteristic of AOT on histology. The next one to think about is CEOT, that is calcifying epithelial odontogenic tumor or Pindbug tumor that can show radio-opaque foci within the radiolucent lesion, similar to that of AOT. However, CEOT tends to be locally aggressive as compared to that of your AOT, and there are some different histopathological features associated with CEOT. Then the next one to think about is adenoid ameloblastoma, and this variant of ameloblastoma may actually show gland-like or tubular patterns that can resemble AOT. However, adenoid ameloblastoma typically has more infiltrative growth as compared to that of AOT, which is less aggressive. Then the next one to think about is keratocystic odontogenic tumor or KCOT, which can present as a radiolucent lesion associated with an impacted tooth, but it is often multilocular and has a high recurrence rate as compared to that of AOT. And think about unicystic ameloblastoma, and again compare the high recurrence rate and the aggressiveness of unicystic ameloblastoma as compared to that of AOT. The next one to think about is CCOT, that is calcifying cystic odontogenic tumor. Now, how exactly to differentiate it from AOT? Radiographically, because you will find ghost cells there. What are the key points here now? So think about AOT as a benign epithelial odontogenic tumor which arises from odontogenic epithelium, likely from dental lamina remnants or reduced enamel epithelium. Next, we talked about different clinical features that we have. Then we discussed histopathology in depth. We talked about how AOT is characterized by proliferation of odontogenic epithelium forming duct-like or gland-like spaces. Then we discussed radiographical appearance of AOT. Then we also discussed that how the fibrous capsule that AOT has, how it restricts the aggressive nature of it. Then we discussed the complications because that fibrous capsule itself limits the complications that arise. Then we discussed differential diagnosis in depth to help you understand how accurate diagnosis is very important. Thank you so much for watching this episode of Dental Digest with the Study Boards. If it added to your learning curve, hit the like button and subscribe to the channel for more updates. I'll see you in the next one.